This is Ed Kim, and
Nicole Starr,
we're at Mission Bay on a Sunday on call, and we're going to talk a little bit about how to deal with post-op care. And
because that's the theme of today.
okay, and it's called the trajectory model. Okay, and we're calling it a trajectory model because it's kind of like your patients are trains, planes, whatever.
They're on a train that they can't get off.
No, stop.
No, they
It's
are.
well, the point is that like a train, there is an expected schedule, a trajectory that they should follow in order for them to reach their final destination and whatever stops are in between. Okay? And the ultimate goal is to demystify postoperative care.
Right, because it can be kind of a mystery when you start intern year.
Exactly. So you want an organized approach to post-op care. And it's not that mysterious because surgery is traumatic. Basically, the damage gets done in the hospital or in the operating room, although some people come in sick.
Right.
And that people have typical and expected trajectory of recovery. And the more you know about these, the better you'll be able to take care of your patients.
And the more you know about your patient, the more you know what to expect. Oh, but there's only a certain number of common complications. So if you know what to look out for, then you'll be ready for it.
Exactly. And part of it also is basically you should know about who to worry about, which patients are going to be the ones that are going to cause problems or have problems, and what to worry about, as you know, regarding what to anticipate and what the initial evaluation and treatment should be. And then this is another concept slide where we want you to think about postoperative care not as so much as you controlling the process, but you're actually just kind of helping the patients heal themselves, because ultimately it's the healing.
Keep your patients on track while they're recovering from surgery.
Exactly. And so you want to look for signs of healing where people are getting back to their regular routine that have been kind of pushed off of their regular homeostasis. So there's specifics of recovery that you should know about, what the milestones of recovery are, and these could vary depending on your service.
But pretty much every service, you want people to be eating, drinking, peeing, pooping, walking around before they can leave the hospital.
Right. They're basically, you just have to imagine what they need in order for them to be at home.
Right.
Right? It's somewhat common sense, but it can also be hard to think that way when you're inundated with labs and vital signs and whatnot. Okay. So there is a typical length of stay for most operations. And again, common complication and issues. So there are only a few.
So when you start a new rotation, every month is going to be pretty different. And it's good to get a sense for what are the main operations that are performed on that service, how long patients usually stay in the hospital, which can vary both by attending and by the actual operation. And then what kind of milestones you're looking for your patients to meet before they can get out of the hospital. And then also what to expect as the usual complications of each surgery.
So for example, on colorectal, we usually do mostly laparoscopic or open colorectal operations, and they usually stay about 5 days or so. Open tends to stay a little bit longer. Sometimes if they're on the fast track, they can go as early as 3 days, and then ileostomy takedowns are pretty much 3 days. Milestones, something that you've already discussed, and then for GI surgery, typically you can see prolonged ileus. Wound infections are very common. Anastomotic leaks, not as, but can be very devastating. So those are the ones that we really keep our eyes out for. And then sometimes pain control can be an issue with certain type of patients.
And that, I think, brings up a good point, is that, anastomotic leaks, maybe not common, but devastating. It's good to know what are the common things that you can expect a lot of patients to have, like a superficial wound infection, but also like the more rare things, but the things that you absolutely can't miss if it happens to your patient.
Good point. So, Nicole, you're on hepatobiliary, right? So
True.
What are some of the things that you're thinking in terms of your cases, or what are the cases that you guys see a lot of?
We do a lot of big surgeries on this service. So we do a lot of hepatectomies, we do a lot of Whipple procedures, and also a lot of big sarcoma resections.
And how long do they usually stay?
They usually stay about a week. 5 to 7 days,
okay.
Yeah.
Okay.
Common things that we see, like, for example, post-hepatectomy, you expect people to be regenerating their liver, so you watch their phosphorus really carefully. And so often preemptively we'll put them on a phos drip. Or after a Whipple, a lot of patients will develop a pancreatic fistula or delayed gastric emptying, which we just had a readmission for.
Okay, great. So, clinical practice or clinical skill is a skill. So it's just like technical skills. You got to practice, and you have an abundance of opportunity, obviously, to practice every day, especially if you're mindful about it.
Twice a day.
Twice a day. Okay. So you should evaluate patients for whether they're doing well or not. And general appearance, I think, can be very important, but often overlooked if you're again overwhelmed with other details.
It's the eyeball test, but you can't say that until you're a senior resident,
Right.
that someone passes the eyeball test.
Well, you need to back it up with vital signs, in-organ function like urine output, O2 saturations, and then the recovery milestone we talked about. And I think it's very important at the end of rounds to basically determine whether you think the patient is where they should be, not quite, not sure exactly, or whether they're definitely going off track, meaning they're not where they should be, and you should start to worry that maybe one of the things that you're watching for, one of the complications you're concerned about, may be developing.
Right.
So you can often you can often predict what's going to happen by basically thinking about the patient and the operation. Those two things are going to help you develop basically clinical judgment and how to anticipate what the course is going to be. So for the patient, you want to think about what their preoperative comorbidities are, because if they're sicker, the sicker you are before the operation, the sicker you're going to be after the operation. More likely you're going to have problems and complications.
Right, and maybe not even sick for the particular disease you're treating, but if someone is obese or they're a smoker or they have diabetes, they're just going to be predisposed to a lot more complications. Right. And then oftentimes, every service is going to have their set of diseases that they are geared towards treating. And so you'll get to know those specific diseases very well.
Okay, great. And then the operation itself, because you have the standard operations, but there's also specifics about, I think, each case that makes them individual, meaning let's say a standard right hemicolectomy may not be standard right hemicolectomy if it was a big patient or the dissection was very difficult. So it's really important that you get a good sign out, and I think this is important for the seniors and chiefs, to give you guys an idea of what the operation was like, whether there were things that they were worried about, maybe not right after the operation because you can be pretty drained, but maybe the next day. Think about what they're worried about. Was there a lot of spillage for whatever reason, and maybe you're expecting a higher risk for wound complications? So that's important. And so the other thing I want to focus on is that we don't want you to tell us that somebody is septic when they're floridly septic. That's not being a good clinician. What you want to do is you want to stay ahead of the patient. That's what Dr. Riley often says. And that means looking for early signs in patients who are high risk.
Right. You should be, anticipating the complication in someone who is particularly sick, so that at the very first sign of tachycardia or a low-grade fever, you're already suspecting that they might need an early intervention.
Yeah, wait for the other shoe to drop. Okay. So some of the common complications for colorectal service is post-op ileus. Often they'll present with distension on the first day or two. Wound infection, you guys already know what that's typically like. Pelvic abscess is a little bit trickier. They often have urinary retention or lower abdominal pain. Ileus can also be a first sign of an abscess down in the pelvis as well. And the anastomotic leak also first sign is often distension in ileus. Okay.
And then there's, the common abnormalities that you look for in all your patients every day. Just vital signs that are abnormal or changes in their lab values are often, urine output is overlooked, but can be a really good predictor of a lot of different abnormal physiology.
Okay, and this is our last slide. And what I want to say is that I think the ideal mentality is to be a cheerful, but be a pessimist, especially for those patients. Identify the high-risk patients, because believe it or not, those are the ones that typically will or can have problems. Somebody who is otherwise healthy and had a very smooth operation, it's really not that likely they'll have problems. That doesn't mean that you shouldn't, care for them or be detail-oriented, but they're the ones where if you have one abnormality in their vital signs, it's not going to rush you to think that the worst is happening. But for the high-risk patients, you should assume the worst, do the evaluation, rule out that they're not having that worst scenario, and then move on.
And it's appropriate as an intern to worry a little bit more about every abnormality, and you can leave it to your chief resident, someone who's, a lot more experienced, to tell you when it's okay to calm down about something or that they're reassured by X, Y, or Z. So you should be a little bit of a fear mongerer.
That's a really good point. And if you're right about being worried, like 30% of times, that was kind of a line drawn in the sand, but that would make you a very, very good clinician.
Or a baseball player.
Or a baseball player, of course. And so we should end with the recognition that your sickest patients are the ones that cause most work for you, but those are the ones that will teach you the most.
And one day you'll be able to see all the complications that you avoid just by acting early and, not letting your patients become the sickest.